The following podcast is part of a certified educational activity titled Improving Outcomes for Patients with Moderate to Severe Plaque Psoriasis, a closer look at individualized care in an evolving therapeutic landscape. Access the entire activity and complete the post-test at peerview.com/FKA860. Downloadable slides and practice aids are also available. In the following certified educational activity, experts discuss the pathophysiology of psoriasis, available treatment options, and considerations in choosing the best treatment for each patient. Doctors Mark Lebwohl and Alice Gottlieb are also joined by patient Joanna Pomerantz to discuss the impact that psoriasis has had on her quality of life.
Hello, I'm Dr. Mark Lebwohl. I'm the Waldman Professor and Chair of the Kimberly and Eric J. Waldman Department of Dermatology at the Icahn School of Medicine at Mount Sinai in New York City. Welcome to this educational activity in addressing unmet needs in patients with moderate to severe plaque psoriasis with the goal of improving long-term outcomes. So let's get started. As many of you know, psoriasis is a chronic disease that can have a significant effect on the quality of life. Therefore, management involves addressing both psychosocial and physical aspects of the disease. Plaque psoriasis, the most common disease variant, is seen in approximately 85% of cases. It commonly manifests as erythematous plaques with thick scale on the extensive surfaces of the arms and legs, on the trunk, and on the scalp. Other less common subtypes include erythrodermic psoriasis, pustular psoriasis, guttate psoriasis, inverse psoriasis, and palmoplantar psoriasis. The severity of psoriasis ranges from mild disease with a limited number of localized inflammatory skin lesions to more severe disease involving widespread plaques that cover even more than 10% of the body surface area and occasionally the entire body surface area. Approximately 1/3 of patients with chronic disease go on to develop psoriatic arthritis, an inflammatory arthritis characterized by asymmetric oligoarthritis in many cases, nail disease, enthesitis, and/or dactylitis. In the last decade, research discoveries have significantly expanded our understanding of the pathophysiology of psoriasis and have directly led to the development of highly effective targeted psoriasis therapies, such as those against interleukin-17 and interleukin-23. Indeed, clinical trial data for monoclonal antibodies against IL-17 signaling, which includes secukinumab, ixekizumab, and brodalumab, and newer IL-23 P19 antagonists, tildrakizumab, guselkumab, and risankizumab, underscore the central role of these cytokines as predominant drivers of psoriatic disease. We are currently witnessing a translational revolution in the treatment and management of psoriasis. Unfortunately, despite the high prevalence of psoriasis and availability of numerous topical and systemic therapies, many individuals remain untreated or undertreated. Considering both patient perspectives and physician experience, today's program is going to take a closer look at challenges associated with the management of moderate to severe plaque psoriasis and explore why some patients do not receive appropriate and timely treatment for their disease. At the end of the activity, I hope you are able to look at these challenges more as opportunities and are able to integrate recent therapeutic advances into treatment approaches that address the need for individualized care and patient engagement and collaboration to optimize outcomes. When we come back, I'll be joined by Dr. Alice Gottlieb, who will lend her expertise to a discussion of current strategies to improve the care of patients with moderate to severe psoriasis in the context of a rapidly evolving treatment landscape. So stay tuned, and we'll be right back. Welcome back. Joining me today is Dr. Alice Gottlieb, Clinical Professor of Dermatology at the Icahn School of Medicine at Mount Sinai and Medical Director of the Dermatology Department at Beth Israel Hospital in New York City. Please welcome Dr. Gottlieb. Alice, let's dive right in. So let's quickly now review the current knowledge of the pathophysiology of psoriasis as it relates to symptoms and therapeutic targeting. There's an elaborate array of cells and cytokines that are responsible for the development of psoriasis. And we now have, fortunately, very targeted therapies that look at those particular cells and cytokines. So for example, before the current generation of biologic therapies for psoriasis, among the first drugs to be developed for the treatment of psoriasis were actually a class of drugs that you identified as targets. You were the first to treat psoriasis patients with infliximab. And I remember that dramatic double-blind study that you published. We subsequently developed several drugs that target TNF: etanercept, infliximab, adalimumab, certolizumab, and golimumab are the 5 that actually target TNF-alpha. And at the time, they were major breakthroughs in the development of psoriasis. Today, we actually have more targeted therapies. Actually, the next one was ustekinumab, which targeted IL-12 and IL-23. And it turns out that IL-23 was probably the key cytokine there. And subsequently, we developed monoclonal antibodies that targeted specifically IL-23. We have tildrakizumab, risankizumab, guselkumab, and ustekinumab. And probably closest to the source of psoriasis are the agents that target IL-17, secukinumab, ixekizumab, and brodalumab, which targets the receptor for IL-17. So we actually have molecules against each of those agents that play a role in the development of psoriasis. So Alice, tell us about your general approach to the treatment of psoriasis. When we have so many treatments, what are the factors you consider that help you pick one agent over another?
So I'll answer the first question first. My general philosophy is the best treatment for psoriasis is the one that also controls psoriatic arthritis, including inhibition of progression of disease. We have 6 drugs that not only control signs and symptoms, improve quality of life, but they actually inhibit radiographic progression. Additionally, they also clear psoriasis, some to a better extent than others. The specific drugs are secukinumab, ixekizumab, etanercept, adalimumab, infliximab, and certolizumab. They all have not only moderate to severe psoriasis, but they also have inhibition of radiographic progression in PSA, controlling signs and symptoms, and also improving quality of life. I would have to say, now if you ask me how do I pick among those 6, if insurance issues were not the issue, I would pick an IL-17 blocker, the 2 that I just mentioned. There are actual studies that have dead-on comparators that show that they work as well in the joints, and it's clear they work better, no pun intended, that they work better in the skin. Mm-hmm. And the safety
They also don't have black box warnings.
I was going to just say, and the safety profile is probably better. Okay. Now let's turn to I'm going to do both extremes of the population. Medicare. Medicare patients don't benefit from some of the coupon programs that make expensive drugs accessible to many other people. And so cost is a major issue. And if I have a Medicare patient and I want to optimize the treatment of the skin and the joints, I will pick an IL-23 blocker, because those can be what's called buy and bill, which means they go down Medicare Part D, and the patient doesn't have to worry about the extra cost with the donut hole and when you pass that $3,700. Right. So now let's take the other extreme, the pediatric population. We have only 2 drugs in the United States that work well and that are approved in the pediatric age group. One of them is etanercept, and the other one is ustekinumab. And obviously, ustekinumab is given very infrequently. Etanercept is given once weekly. I can't think of a more needle-phobic population than children, so given my choice, I would pick ustekinumab, which at this point is only available down to 12-year-old. The etanercept is available to a younger population by FDA label. Now, what happens when I'm in a rush and when I have a patient who has unstable severe psoriasis who just can't stand it anymore? Then speed is important. And the 3 drugs that work the fastest, bar none, are secukinumab, ixekizumab, and brodalumab. And I just had a patient today who I saw who basically after a week and a half of one of those drugs is clear.
Right.
It's miraculous. Now, taking off-label use, if you have somebody who has bad pustular psoriasis and generalized pustular psoriasis, this is approved in Japan, but not here. You want an IL-17 blocker because you want that patient is potentially medically unstable, and you want to clear that psoriasis in a hurry.
Yeah. So patients who are very ill, have severe, almost dangerous psoriasis. I agree. IL-17s are the way to go. They're even faster than cyclosporin.
Yep.
The other thing that happens, I'm sure it happens to you because it happens to all of us, the patient comes in and they say, they're covered head to toe, they say, I'm getting married in 4 weeks, can you clear me? And that's not very easy to do.
Right.
But the IL-17s are the fastest drugs we have, even beat cyclosporin. How about some of the older treatments? What's their role been? It sounds like because of the safety profile of the older biologics, you've moved on to the IL-17 and IL-23s much more. I certainly have as well. What about the oral drugs? How often do you use them? Methotrexate, retinoids, cyclosporin, apremilast, which is not an old drug?
Methotrexate is still used a lot. It's especially used by the rheumatologist because, first off, often insurance will require the use of methotrexate before. But in addition, especially in rheumatoid arthritis, there are data that show that methotrexate plus, name the TNF blocker, works better than alone. In psoriatic arthritis, that's not nearly as clear.
Right.
And for the newer biologics, when that's looked at, it doesn't make a difference,
Right. except
except that the patients have more nausea and side effects.
Right.
And of course, if you deal with women of reproductive potential, methotrexate is, if anything, worse than isotretinoin because it's an abortifacient and a
Right.
mutagen.
Isotretinoin is pretty bad too.
Yeah, but methotrexate is even worse. It's in the morning after pill, right?
Correct.
And so, and in the case in psoriatic arthritis where there's axial spine involvement, you are not to use methotrexate. It simply doesn't work, okay? The other place I'll use it is if I have a patient who has a history of lymphoma or a recent cancer. Methotrexate is often used as chemotherapy.
So, I will say, when we call oncologists, they actually tell us to use methotrexate.
Right.
The problem is when you look at case series of drugs associated with emergence of lymphoma, for example,
Understood.
you put a patient on methotrexate, a lymphoma comes out, you stop the methotrexate, and it goes away just because you stop the methotrexate.
Understood.
So I actually don't use it in that setting. And actually, we should talk a little bit more about the data on malignancies.
Yeah.
Of the drugs out there, the one that clearly emerges as being beneficial are retinoids. They make squamous cells and basal cells disappear, and they prevent them from coming out.
Use for retinoids is in either the Medicare patient again, or in cancer patients, because assuming the patient doesn't have psoriatic arthritis.
Right.
But because retinoids, especially in combination with phototherapy, they work well for psoriasis, and the retinoid may have anti-epithelial cancer effect, and so that's how I would use it. Cyclosporin, used much less than I used to, but generally I'll use it when I need something that works fast and I can't get them an IL-17 blocker and they don't have kidney disease.
Right, me too.
And
That's exactly how I use it.
Apremilast I don't use so much.
It's a pretty benign drug. And its mechanism of action is a phosphodiesterase 4 inhibitor. and which, caffeine is a phosphodiesterase inhibitor. So I believe even though there's not that much data, now as more and more patients have been treated and data is coming out, it does look like apremilast is pretty safe. So I often use it in the setting of malignancy, for example. I prefer it to methotrexate for combination therapy. It does add a little boost to our other treatments. It's much safer than methotrexate.
I like to use apremilast in combination with biologics when they're not clearing the patient entirely. And the safety data that allow me to say that are the data coming from the Corona registry, which is a large registry of patients mainly with psoriasis on various systemic treatments. And when you looked at the use of apremilast, a lot of it was being used in combination with biologics, especially in the psoriatic arthritis population, I may add. It works, but in addition, it's safe. And and that's important because dermatologists and rheumatologists use a lot of combination treatment, and it's good to know that apremilast and biologics are safe and actually can make some of these drugs more effective.
Yeah, I must say in my practice, apremilast has pushed out methotrexate more and more. I think it's much safer than methotrexate, and I do use it in combination often. Alice, what do you think of the recent guidelines that came out from the American Academy of Dermatology and the National Psoriasis Foundation?
So I will point out, and I have to admit, showing my prejudice as a dermatologist and a rheumatologist, that it is now standard of care that a dermatologist needs to educate a patient about psoriatic arthritis and alert that could be a possibility. They need to screen for it, and they need to make sure the patient is getting adequate care, whether they take care of it themselves or refer to rheumatologists. And psoriatic arthritis is the major comorbidity, and I think it's really important that that's considered standard of care. The guidelines also mention that one needs to make sure that some of the cardiovascular risk factors that are associated, especially with moderate to severe psoriasis, and even more so if you have psoriatic arthritis, that the dermatologist makes sure that if they're not taking care of it, that primary care is. So I tell patients, I'm going to make you beautiful or handsome on the outside, but I want you to be beautiful or handsome on the inside.
That's a very nice
and
comment.
so, and because, and I actually make sure I'll ask them, I say, did you visit your primary care doctor? So, yeah.
So I say something as simple as, do you have any joint pain? Just a simple question like that. We are not taking optimal care of our patients if we don't ask that one easy question. Do you have any joint pain? And that does affect the treatments that we use.
Absolutely. And I'll give an important example. Some people argue you don't need to ask about PSA because the treatments that work for moderate to severe psoriatic arthritis work for arthritis. However, what's wrong with that argument is you can have patients with minimal psoriasis who have severe psoriatic arthritis. And if you don't, you have to ask every patient at every visit, about their joints. At minimum, ask that question, do your joints hurt? Because it can be the patient who has almost nothing.
Right, and actually, even though many of the treatments we have are approved for psoriatic arthritis, and you actually mentioned this very well, ustekinumab doesn't have a protect against the radiographic progression of joint disease, but it's approved for psoriatic arthritis. There are many reports of patients who were on TNF blockers, their psoriasis wasn't doing well, and their joints, they didn't even know they had psoriatic arthritis. They go on ustekinumab, their skin clears up, and their joints get miserable. And there are many, many reports of that. So it really is important for us to know if the joints are affected.
Yeah, and so I think that was important. I think I'm talking about new stuff. And I think there was a big emphasis on cardiovascular comorbidities. I do not think dermatologists should be primary care physicians, nor do I think they're qualified to be good primary care physicians, but they are important to work with your primary care colleagues and make sure that that is taken care of. I think you and I know how to use a stethoscope and still use a stethoscope, but most dermatologists don't even have one in their office. Right. So how are you going to ask them to take a blood pressure?
Right. I do actually occasionally still use a stethoscope.
Yes, I do too.
Very recently I had a patient with a supraventricular tachycardia in the office, and he was just not feeling well. And we took his pulse and blood pressure, and they couldn't get an accurate pulse. And I listened to him, and he had this supraventricular tachycardia. We ended up hospitalizing him that day, which we fortunately dealt with, and he did recover completely. He is actually on one of the IL-17 blockers.
But that didn't cause it, right?
That did not cause
right.
it. No, it did not cause it. Actually, in fact, since we're on the subject, the class of drugs that has the most data, mostly from registries on protecting against heart attacks, has been TNF blockers. But there is some new data suggesting that IL-17 blockers do it perhaps even better. Mm-hmm. And I think that in the end, when we have lots of registry data with all the drugs being used for years, the ones that work the best are going to reduce inflammation the most and probably benefit cardiovascular disease the most. And I do think we're going to eventually get that, although right now the TNF blockers have the best data. So any other clinical pearls you'd like to share with our dermatology colleagues out there who are managing patients with moderate or severe psoriasis? For example, when one drug fails, what's your pattern there?
Okay, so if let's say they're on a drug, let's limit it to biologics for now. One biologic fails, I want to know, did it never work well, or did it work well and then it started to poop out? And if the case is it never worked well, it's very clear you change the target. If it is that the patient liked the drug but it didn't work, then I probably still would change the target, but then another option is switch to a different one within class. So that's kind of my general approach.
Okay, and the Psoriasis Foundation has come out with a goal of treat to target, meaning there should be very little psoriasis left. What do you think about that? Is it realistic?
I'm not sure whether I would pick the same target, but I do it all the time. I put in every chart a physician's global assessment and a body surface area. I want to know how extensive the disease and what is the quality of the lesions that are there on average. And also I tell the patient, and this is exactly what I say to every patient. I said, what's the difference between a Jewish mother like myself and a Rottweiler? And the answer is the Rottweiler, let's go. And my attitude is I won't stop till I clear their psoriasis and fix their psoriatic arthritis if it's relevant. And I think that the goal is not whether you get FDA approval or whether you get an article in the New England Journal. The goal is when the patient gets to the right doctor and their psoriasis is clear and their psoriatic arthritis is not affecting their daily tasks of living. And so,
right. So I certainly would agree that when patients are happy, I do let go. Mm-hmm. But if there's any unhappiness, then I think that we have such great tools that we should be able to get them to the point where they truly are clear. Alice, thank you for a great discussion.
Thank you for having me.
Truly a pleasure. When we come back, Dr. Gottlieb and I will be joined by a patient, and we will further explore some of the real-world considerations in managing patients with psoriasis. So stay tuned, and we'll be right back. Welcome back. Building on our previous discussion, Dr. Gottlieb and I will now be joined by a patient, and we will take a closer look at some of the practical considerations when it comes to personalizing the care of patients with psoriasis. Please welcome Ms. Joanna Pomerantz. So, Joanna, we're going to ask you a lot of questions about your journey with psoriasis. And so start out with how and when you were diagnosed.
So I was diagnosed at 9, but I actually had symptoms when I was 6. I was taken to a pediatrician and they misdiagnosed it. I can't remember exactly what it was diagnosed as, but it was predominantly on my scalp. And then at the age of 9, I was taken to a dermatologist and it was officially diagnosed then. So
what kind of treatments have you had since you were a child?
So when I was younger, since it was predominantly on my scalp, I did a lot of tar treatments, which were disgusting. I would put tar on my scalp and put like a shower cap and sleep overnight with it. At the time when I was young, there wasn't really a lot available. And I actually before I was diagnosed, the doctor had told me to go tanning in a regular tanning bed, not Puva lights, just regular tanning. So I remember being very young, being in the tanning beds while my mom would sit next to me. It was an odd experience. And then I actually went to Aruba and I got very sunburnt and my psoriasis disappeared for 6 years actually. Wow. Yeah, which was pretty interesting. But then it came back in full force. So at that time, what was available was really topical. So many different ointments that were greasy and gross. And methotrexate was suggested, but I was very young. My parents were very worried that that would be too aggressive, so I never tried that. And then as I got older, more biologics became available, and I went through numerous biologics until I found the right one.
Okay, good.
Yeah.
Good. And how's that working for you?
It has changed the course of my life, both physically and mentally.
Okay, that's great.
Yeah.
And in terms of your interactions that you've had with the doctors and other people in the healthcare field that you've worked with, can you help other patients give them advice about how to best interact with their physicians or other people that take care of them?
Yeah, I think the most important thing, the patient is the expert in what they feel. And obviously the doctor is the expert in what they're treating. But being able to feel comfortable with their doctor, knowing that they'll take the time to sit down and talk to you is super important. Yeah, I think, as I mentioned before, psoriasis is not just physical, it's mental, and it's really important for the patient to feel heard. So if the doctor isn't going to take the time to sit and really talk with you, that's important to note.
Okay, I'm actually glad you said that because, you know, we're being viewed by large numbers of dermatologists, all of whom go to work and they have pressure on them to see a lot of patients a day.
Yes.
And so we don't have a lot of time. And there are any tips you can give to the doctor in terms of how to deal with your patient in an efficient way so that, you know, you're not taking that amount of time but still helping the patient a lot?
The patient giving tips to the doctor. That's an interesting question. I think I do realize that, you know, the doctor has a lot of patients to see, but sometimes just an extra couple minutes with the patient, and again, asking them how they're feeling and how they're doing today can go a long way. Not just feeling like a number when you're in the office, you know. Patients can really sense that.
Sure.
Yeah.
Okay. And how do you find doctors who, you know, are great with psoriasis? And you mentioned your pediatrician who didn't recognize it for several years. And I think a lot of, you know, general physicians who don't specialize might not recognize psoriasis easily. How do you go about finding a physician?
Reading patient reviews is really important. The National Psoriasis Foundation has a list of doctors that they suggest, and you can read up on them. And I think it's important to do your research before you go to a doctor. And also just being connected with other patients to hear what their experiences were is really important too. And sometimes you have to doctor surf, you know. It's not always the first doctor that you go to that's going to feel like the right fit. I think it's interesting when talking about treatments too, because when you're offered different treatments by doctors, being able to understand what it's actually treating. And that goes along with, I think, finding a good doctor, taking the time to explain this is what this will be treating. Because over the years, I've had doctors just throw medications at me and not really explain what it was for.
So I'm intrigued by the comment you made about getting a sunburn and having it go away for years.
Yeah.
And is there any advice, or have you tried that again? Have you tried to get a sunburn again?
Well, I went to school in Miami for, not to be sunburned, but to get exposure to the sun. Because I was always under the impression the sun was the best thing for my psoriasis. And again, when I was in college, more treatment was becoming available. But I found after I was in the sun, was when I would feel my best.
Yeah.
So, and it was quite a wild thing to have your psoriasis disappear and think that you were clear of something, and then just to come back, it was a bit haunting, actually.
Yeah. And I imagine when you begin to see it come back, does that have a bad psychological impact on you?
100%. Again, I mentioned the mental health piece before, but especially when you're a teenager going through, social events. I was a swimmer as well, always being looked at. There was always this thought of, what are people thinking? Do they think I'm contagious? Feeling almost like a leper, and having to deal with that piece along with like seeing yourself in the mirror. It's very difficult.
Yeah.
Yeah.
No, I can imagine.
Yeah.
Fortunately, we're in a better era now.
We definitely are.
But there was a time when the best treatment we had was phototherapy. It was pretty safe.
Yeah.
And it worked reasonably well.
Yeah.
We'd get the majority of patients, 60% of patients would, we used to use the word clear for somebody who was a lot better, but certainly not clear.
Yeah.
Now when we use the word clear, we mean it.
Yeah.
We really achieve PASI 100, where you get 100%, there's not a dot of psoriasis left. We didn't really have that until the current era.
Yeah, so I had actually done the phototherapy as well, but I found it was quite time-consuming,
Yes.
And the whole process of it was, I don't know if the word shameful is the right word, but they would put a pillowcase on your head and you had to put mineral oil.
Right.
It just was an awful kind of experience, and also being impatient, wanting to clear up right away, and it takes a very long time. So I never really liked the lights. I might not have given it the right time though.
Right,
Yeah.
right. I will say, thinking about taking, off time 3 days a week, and our phototherapy center is open 6:30 in the morning till 8 at night, and we open up weekends. But we did that to make it convenient for patients. But imagine centers that are open 9 to 5.
Yeah.
What job is going to put up with that?
Yeah, it's an impossibility.
Yeah, do you think that psoriasis has impacted your job at any point or in any way?
It's interesting because I actually work in the mental health field. And so I think a lot about, I reflect back on what I was feeling at the time, because when I started actually in the work field, I had been on a biologic that had been working for a while. So the thought of psoriasis really didn't come to me like it did every single day when I could see the physical symptoms and feel them. But I think often how it impacted me and how I would kind of cope with it. And I think there needs to be more talk about the mental health piece. But I might be biased because I'm in the field.
Right.
So, yeah.
Alice?
One thing I would like to bring out is I think it's important to talk to all your psoriasis patients, even those who have, quote, not severe psoriasis, because first of all, it might be severe to them. Somebody in a profession where they have it on their hands and somebody doesn't want to shake their hands, they have it on their face, or even it can be just somebody where you don't have a good reason. It bothers them. And the other thing is that it's important to talk to your patients, because I think it's important for patients to know that we care about them as people.
Yeah, I would definitely agree. You're not just skin doctors. Actually, my skin doctors saved my life. That's how I look at it, and actually gave me a life to live, which I'm very grateful for.
Okay. Well, thank you so much for being here.
Thank you for having me.
I hope you found this discussion useful for your practice. Thank you for joining us.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FKA860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.